Welcome to this session on hip fracture update. I'm Kitish Mahanti. I'm a trauma surgeon working here at the University Hospital Wales in Cardiff. We know hip fractures are common, the kind of bread and butter our practice. We can't get away from them. When I started as a consultant in 2005, the reported incidence was around 43,000 in the UK. Last year, it's grown up to 74,000. So we all probably appreciate and realize that in any age group, hip fractures are life-changing injuries. So it's our duty of care that we should do our best for our patients. Are we doing it? That's the question. We all know how to treat hip fractures, I'm sure. But the objective of this session is to update our knowledge, and also we need to kind of learn about emerging trends and new research. So let's go ahead. This is my first case, a 42-year-old female, high energy crash, no other injuries, is only an isolated fracture. I think we all will agree that needs fixation. But when should we fix them? How do we reduce it? How do we fix it? There's so many questions that pop in. And remember, 3 to 4% incidence, so every DGH is expected to get 10 to 15 of these a year. So to discuss all these facets of this fascinating injury, I would welcome Mr. Bob Handley. Mr. Handley works out of Oxford, is one of our senior most consultants in orthopedic trauma. He's currently the president of British Orthopedic Association, but I'll tell and elaborate on that a bit later. I think let's go straight into it. Welcome, and over to you, Bob.
Good afternoon. Thanks very much, Kitish. It's a pleasure to almost be there with you, but I'll do my best from a distance. So the topic that you've introduced and that I'm going to talk about is high energy or young hip fractures. And so I think that it's worth considering as to why they're different from other hip fractures, the regular NOF that we see. And we need to be honest with ourselves when we look at these things. And I think they're people like us. They're more often, well, I'm growing out of that us age now, but for you, they're the people that look similar to yourself. They're younger and they've got an injury that you can empathize with more. You're likely to follow them up, whereas the vast majority of hip fracture patients in the UK that are dealt with in the regular NOF group, the older patient, we never follow up again, and we have very little personal idea as to how they're doing. We do know that the younger patient's going to have greater demand, so they're likely to put whatever construct we implant in them to a greater test. Their life expectancy is greater, and so that makes us much more wary about using an arthroplasty because we're not so sure about the long-term consequences of that in somebody who may have completely otherwise healthy joints. The life expectancy being greater means there's more chance of it failing, but we've got the great opportunity of what we believe is good bone, so we can do our good carpentry job on a sound specimen rather than the older osteoporotic bone. So what is fate and what can I control? Well, if you look at the injury factors, there are the things that the initial displacement, the anatomy of the fracture or its fracture location, whether there's comminution of the fracture, and in particular about the anatomy, people talk about the Powell's angle, of which a little bit more later. The technical factors that we've got, what can I control as a surgeon? I can decide to do the operation at a particular time. I can achieve a better quality of reduction. I can choose to decompress the capsule, and I have a choice as to what fixation construct I'm going to use. So we'll look at some of these aspects, and I'm very grateful to Kitish because he allowed me to steal a presentation of his, and I've taken bits out of it and just magnified some of them. I put this one in because time of emergency surgery, and this is from Mark Swinkowski in 1984. And the two reasons for putting it in are firstly the figures that are there, that you see that he had a zero non-union rate with his early surgery. But more importantly, for the way in which I wish to consider this, is I think we learn an awful lot by the people that we've worked with. Whether we like it or not, we tend to follow things and copy the people that we've respected. And I was Mark's fellow. I was Swinkowski's fellow when I was in Seattle. And so a lot of my practice was shaped by what he said. And so early fracture treatment I thought was important. And when the later evidence came along that it probably didn't make that difference, I took a little bit of convincing about that. But it would seem to be the case that there is not a huge advantage in early surgery, and it's probably better if you operate on it in the cool light of day and you deal with it with an experienced team rather than rushing it in the middle of the night. So, no association between timing of fracture and AVN, and delay of more than 24 hours may increase the risk of non-union, but I don't think most of us would be talking about delaying more than 24 hours. It would be whether we go beyond the night of presentation. Capsular decompression, well, that was something else that Mark was interested in, because the reason I went out to Seattle in the first place was to look at laser Doppler flowmetry in bone, and he'd looked at the blood flow in rabbits in various instances, and capsular decompression he thought was an important aspect of it. And the figures, so if we look at displaced fractures, numbers that developed AVN in those that had decompression and those that didn't, there's a higher incidence in the displaced fractures. And so that there is a notion that may be important, but subsequent evidence has not really proven that to any great degree. And so it's not a regular thing that the majority of people do for itself. They may do it as part of another procedure. Screw placement, well, what we can learn from the older patients and what we shouldn't reproduce in the younger patients is if you're using screws, don't start their entry point below the lesser trochanter. That's associated with a high incidence of subsequent fracture propagated through what may be multiple fracture points, because if you've got 3 screws in there, there's almost certainly more entry points that you've had a go at in trying to get the adequate position. And so don't start too low. So what type of fractures do you get, and are some suitable for screws? Well, I show this because in Oxford, we do see high energy or young hip fractures, but the high energy tends most frequently to be a direct application of that energy. And this is a typical Oxford winter cyclist, a 39-year-old who slipped on an icy road, and you can see that they've got, from the CT, its valgus impacted. So although it's a little displaced, the blow has come on this skinny patient right over the greater trochanter as they slipped and not got their toes out of the cleats, and they've impacted it. They're fixed in situ. That's not reduced. As you can see, they're fixed in situ and subsequently have healed very nicely and is back cycling. And one of the patients that we did this on came in the following winter, and he'd taken a different bend and done exactly the same to his opposite hip. He hadn't learned his lesson. We fixed it the same way, and he did well twice. So talk about the Powell's angle. So Powell's, he commented on the association between the more vertical orientation of the fracture and a poorer outcome. And this tends to be associated with shearing forces at the fracture site rather than impaction or angulation. And shearing is bad for fracture healing because it means the strain environment is the same across the whole fracture plane. So you can't get spot welding or healing just where it's optimum. It fails across the whole plane. And in Powell's 3, screw fixation, as I showed with the impacted fracture that I had, is not nearly so appropriate. It doesn't stop the shearing force to anything like the same extent. And so fixation with a fixed angle device, such as a 2-hole DHS, is more appropriate if you're just going to use that fixation in isolation. And so you can see that there is disagreement still as to how you might do this. This was from a paper in 2017, and in it had an OTA survey of their surgeons attending as to what they would use for a Powell's 3 fracture. And the majority, 47%, said a fixed angle device. And that is what tends to be shown of the simple devices to be the better method. However, if you use the analogy of another fracture where you worry about shearing, to stop the shearing in this fracture that you're all familiar with fixing, you put an anti-glide plate at the apex of the fracture. And that is quite possible with with a hip fracture too. So in this instance, as well as the screws that have been placed, just as with that tibial plateau, capturing the apex of that of the fragment is an anti-glide plate. And this does seem to be a more stable way of fixing these fractures. And in the paper that Yi put together, where they had 28 younger patients, they had 89% unite without femoral neck shortening. And as you're aware, in the younger age group, one of the things you want to do is preserve the overall anatomy of the hip, just as you would do when you're putting a total hip replacement in. So it may be that this adjunctive plate is a better way of approaching it. They put theirs in through a Smith-Peterson approach, which they also used to reduce the fracture. Which brings me on to quality of reduction. And this would seem to be the most important thing. Now, going back to Swinkowski, when I worked with him, he let me reduce the fractures closed, and I would do that, but then he made me open it, and then I saw that my closed reduction didn't look nearly as good as it did on the image intensifier. So I've tended to be an advocate of open reduction in a younger patient, because I don't believe that I can adequately reduce the fracture closed or assess the reduction. That also now gives you the opportunity, if you've done an open reduction through a Smith-Peterson, to put that adjunctive plate on there. So I think quality of the reduction is vital. And if you do have an inadequacy in your reduction, make sure it's not varus. So open or closed, I think I've said that now. My tendency is to go to open. The evidence for that is not that great, but you don't see enough to gain significant experience yourself. So you tend to do what you're comfortable with. And so I do an open reduction. And this is just to show why you want to get it right the first time. As you know, girth is the other string to my bow. Get it right the first time, then you don't end up having to do this, having to do osteotomies, correct the fracture plane, and do this, which can heal, but in a young person is not a situation you want to be leaving yourself open to. So in summary, don't operate in fractures in the middle of the night. It's not necessary. If you're not entirely happy with a closed reduction, open it. Screws are good for horizontal fracture lines or in practice fracture lines, but a fixed angle device is stronger for a PALS 3. But now I think that you may use screws with an anti-glide plate on there. But quality of reduction is critical. Avoid varus. Thanks very much.
That was very instructional and enlightening, as expected. So I haven't got any questions at the moment on the chat box, so we'll probably save that for the later. Let's move on to my next slide. Could I have my next slide, please? Sorry. So we're going to another age group. This lady is 74, mobilizes independently. There's no cognitive impairment, no medical comorbidity. I think all of us agree that, again, this patient needs an operation. Are we fixing it or are we replacing it? If you're replacing it, are we doing a hemiarthroplasty or a total hip replacement? Where our National Institute of Clinical Excellence, or NICE, would probably, has already advised us or guided us that we should consider doing total hip replacement in this fitter individuals with the criteria that I've already said. So are we overdoing it? We were criticized as trauma surgeons that apparently only 1/3 of the people who fitted this criteria had hip replacement over the last few years. But there is some new research, and it's my pleasure and honor to welcome Professor Mohit Bhandari all the way from Canada. Mohit is currently the professor and academic chair of McMaster University, and he is a world-renowned orthopedic trauma researcher. He's written thousands of papers, and his hallmark is to carry out multinational, multi-center randomized controlled trial. It can't get better than that. Mohit has done intense research on hip fractures recently, and we would love to hear his views about management of this elderly patient with hip fractures. Over to you, Mohit, and welcome.
Once again, thank you so much. And I look forward to sharing with you, if I can, just where we are with respect to this key issue. Now, there are probably more than 5 publications that I could speak to, but these are fairly important ones. And I also had the privilege of working and continue to work with Mark Swinkowski, as Dr. Handley also mentioned his interactions. There is a review in New England Journal of Medicine that he and I wrote in 2017. That's one of the reviews worth, I think, reading, and only because it helped me and him summarize some of the evidence in this area. But I will focus on a few key areas, and I will put a little emphasis on a few large randomized trials and a meta-analysis of trials. But here, my friends, is the simple truth. Hip fractures have a high mortality rate. They have a high rate of morbidity. They have a profound impairment of independence. And the truth is, we still have not sorted out the revision issue. So there are even, if we look at studies that have come out over 20 years ago, the revision rates haven't necessarily improved substantially. If you look at this simple graphic that looks at mortality versus the quality of the studies and the studies over time, if you look at the 1980s, 1990s, and into the 2000s, we actually saw that mortality after hip fracture wasn't decreasing. It seemed to be, if at anything, increasing. So we have work to be done. I think we could also argue that while we have had lots of research, the optimal approaches to fixing and replacing fractures still remain absolute. In terms of the absolute choice is somewhat inconclusive. Now, we have algorithms, and I'll share with you where I think the evidence is taking us. But also ask yourself this: in what other field would we have tolerated high surgical failure rates, except for 50 years in the management of this particular injury? But let's fast forward to where we are today. Have we identified the ideal implant? Now, this research came out some years ago. This is some work that was done with a number of individuals who ultimately ended up working together on some trials. But the first comparison was, do we fix or do we replace the elderly femoral neck fracture? And when we looked at revision surgery, it appeared that replacement reduced the risk of revision by a substantial margin compared to internal fixation. So when in this frail elderly population, there did seem to be an advantage to arthroplasty. Those who were having revision surgery were having non-unions, and as well you saw evidence of avascular necrosis. Those having arthroplasty weren't complication-free. In fact, with total hip replacement, you can see here just under a 7% risk of early dislocation. I want you to remember this now. This 7% risk was based on dislocations over 20 years ago. And we'll see if the updated evidence helps us. But the question still remains, in those patients, if arthroplasty is a preferred treatment, what do we do? What is it? Is it a total hip arthroplasty or a hemiarthroplasty? So this brings me to the health trial. This was the hip fracture alternatives of total hip arthroplasty versus hemiarthroplasty. This was published not that long ago. And many surgeons, many countries, and many clinical sites. And simple question, it was to determine the effect of total hips versus hemiarthroplasty on unplanned secondary procedures within a 2-year period. You can look at the general inclusion criteria, but these were low energy fractures in which adults were ambulatory prior to the fracture, and these were displaced femoral neck fractures. We included just over 1,400 patients, and we had fairly good follow-up at 2 years. Now, the typical patient, I suspect, is not unknown to many of you who are treating these patients. Female gender, 70 years of age or older, independent ambulatory at the time of the fracture, sustaining a subcapital displaced fracture. When we looked at the overall primary endpoint with respect to revision within 2 years, you can see the numbers are near identical. And in fact, there was no difference overall between a total hip arthroplasty and a hemiarthroplasty in that 2-year period. In fact, when we looked at mortality, no difference. When we looked at differences in function, and this was an important one because we had believed that function would be dramatically improved with total hip arthroplasty in that early period. In fact, we did not find a clinically important difference in function. If anything, we found that the total hip replacement in that patient population was clearly a larger, more serious procedure and also led to more serious adverse events. So among patients with displaced femoral neck fractures, the incidence of secondary procedures over 24 months did not differ. And in fact, there was a clinically unimportant improvement of function and quality of life at 2 years. with a potential increase in serious adverse events. So you can see in that 2-year period, there didn't seem to be a particular advantage to a total hip arthroplasty. But what about going further than 2 years? Going out to 5 years, for example. There were many who said, the health trial didn't follow patients long enough. Well, we followed up in the Journal of Bone and Joint Surgery with a meta-analysis of 16 randomized trials looking at a similar topic. Keep in mind, though, that of the 3,000 patients, over half of them were just based on our health trial. So it was a large driver of the overall results. Once again, when we looked at all the data, there was no difference in revision up to 5 years, but we also again found from a pooled meta-analysis of trials, no clinically important difference in functional outcomes, and only a small difference in operative time that would be favoring the hemiarthroplasty. So again, based on moderate certainty evidence, we found no conclusive rationale for total hip arthroplasty over hemiarthroplasty in that first 5-year period. Now, in ortho evidence, we looked at one more time period. What happens after 5 years? Maybe the advantage is a longer term advantage. And as you would anticipate, the advantage for total hip arthroplasty did appear to show its support in the longer term follow-up. So those patients who had longer term follow-up with total hip replacement versus a hemiarthroplasty did in fact seem to have overall lower rates of revision and overall better outcomes. One point I will make, and this is becoming more and more of interest, has been the issue of in patients who are being treated with hemiarthroplasty or arthroplasty, should we be cementing the canal? And in fact, if we look at recent evidence, and this is one example in JAMA, but there are numerous examples coming out that among patients with hip fractures treated with hemiarthroplasty in a large US healthcare system, uncemented fixation compared to cemented was associated with a statistically significant higher risk of aseptic revision. So there has been a big push towards thinking cementing and the concerns around uncemented prosthesis leading to high revision, but also in recent studies, higher mortality rates in that early setting. Does that mean, though, that we shouldn't be fixing any of these fractures? Should we abandon fixing fractures, femoral neck fractures in this particular patient population? Well, there is arguments that, fixation is less blood loss, less OR time, possible decrease in mortality risk. And the truth is, even if we have high revision rates, we may also have a number of patients that will never need a reoperation. In fact, 2/3 of those. And truthfully, patients, when given the choice of having retaining their femoral head and fixing it versus replacing it, seem to prefer that option. In a patient preferences study that was conducted, we identified that 56% of patients preferred internal fixation over arthroplasty due to the following issues. They had less invasiveness, less blood loss, shorter operating times as big drivers, and the perception that it's because it was a smaller, less invasive procedure compared to an arthroplasty, that it would also help them with respect to mortality risk. Mark Swiatkowski, as you've heard a few times, has had a strong recommendations for fixation, saying, well, we need a, quote, perfect reduction, hence his propensity to open fractures rather than close, reduce them. He's talked lots about capsulotomy, the inferior screw, and the critical inferior and posterior screws. All of these have already been beautifully presented by Dr. Handley, so I won't go into that detail. But I will focus on one area that I think is important. When we fix these fractures, we have long accepted that, well, healing is the prime importance and shortening is of secondary importance. But as we think about patients in modern day, most patients do not accept limps and pain because of a shortened femoral neck that may otherwise be healed. So what can we be doing to limit that degree of shortening? And in fact, shortening and collapse, can have impact. Shortening is common, both in displaced and undisplaced fractures, as we've seen in our previous literature. And that led us to a trial called the FAITH trial, which was another large study of 81 centers across 8 studies, where we said, well, is there a better alternative to the multiple cancellous screw fixation approach to femoral neck fractures, both in the undisplaced and displaced fracture patterns? When we looked across these 366 surgeons who participated around the world, including sites in the UK as well as India, we had a couple of very simple findings. The sliding hip screws did pretty well overall when it came to management of displaced femoral neck fractures. Now, we're not saying that you should be treating all displaced femoral fractures with fixation, but should you decide based on individual patient characteristics that a fixation would be appropriate, considering a sliding hip screw would be a reasonable alternative. In fact, we found that sliding hip screws perform better in patients with displaced fractures with base of the neck, the basicervical, as well as those patients with other risk factors for non-healing, such as smokers. So what is the road ahead? Well, evidence is still not yet identified optimal arthroplasty or internal fixation. We continue to get closer and we develop algorithms, but we have more work to do. Maybe it's about time. Maybe it's about how quickly we get patients to the operating room. We're doing studies just to sort that out. Rapid treatment in and of itself may be the answer. Biologics may also play an answer, although in the past we've had some difficulty getting biologics to demonstrate clinical efficacy. There's lots of opportunity for us to be considering in the future. But at the end of the day, friends, it is going to require all of us to work together through large collaborative trials. Thank you.
Thank you, Mohit. That was absolutely fascinating. And congratulations on this work that you're doing. In the UK, at least, we tend to cement all these elderly people. And I think gradually we are coming to the fact that we should offer hip replacement for fitter individuals who are going to live and enjoy life beyond 5 to 10 years. So but I think it will all get resolved with time. Thank you for your effort. There are some questions popping up in the chat box. I think I'll hold on to them, and if the panelists kindly hang on till the end, depending on the time, we'll discuss one or two important ones. So let's just move outside the capsule. This is that dreaded, unstable, extracapsular fracture we all get to see almost once or twice in a week. The posteromedial buttress is gone. So we know that sliding hip screw probably will not work here. Should we nail it? Or how do the patients do? How do they regain their function? Is there any other solution available where we can start prompt pain-free mobilization for this elderly group of patients? So to throw more light on these topics, it's my honor and delight to invite Mr. John Mukhopadhyay. John is a veteran AO teacher. He is the head of the department of Paras HMRI Hospital in Patna, India. So thank you, John, for joining us from such far away. He is also the chairman of the Research and Education Council of India, and he is a well-known trauma surgeon in that part of the world. Welcome, Jay. Over to you, John.
Thank you, Kitish, for this kind introduction. It's a pleasure to be here with all of you. I was in the last BIOS meeting that I attended was in Manchester, where I was invited as part of the Indian summer. So I'm going to talk about unstable trochanteric fractures. Basically, no conflict of interest regarding this presentation. And we're going to look at some of the problems associated with the fixation of these fractures and try to define the role of arthroplasty in them. The problem that we see very often with trochanteric fractures, although personally I still believe fixation is the first priority in most of these fractures, and the options could vary between a nail and maybe a sliding hip screw with a side plate or wiring of the trochanter. So this would be my usual practice for most unstable intertrochanteric fractures. However, there may be some fractures which would be better off with a primary arthroplasty. The second area is obviously with failed fixation. And here, I think the indications are a little clearer, and often an arthroplasty is indicated. The problem we see every now and then is, in spite of what method is used, whether it's a nail, a plate, a locking plate, a sliding hip screw, or a dynamic condylar screw, we see failures with these fractures only far too often. And often it may be evident in the initial fixation, but there are times when fractures look pretty reasonably fixed, but unfortunately fail pretty quickly after the initial fixation. And this is an example of a trochanteric fracture nailed, of course, with 2 screws, which may not be the best implant, but it failed within a period of short time of 6 weeks the fracture had gone on to fail. So it's interesting. Obviously, many people have had this experience of failures. And Dr. Bruce from Leuven was one of the first people to actually publish on this. And they looked at 102 patients which they treated between 1980 and 1984. And this was before the sliding hip screw became very popular. And they found that they had very good results with it. They found the mortality to be no higher than internal fixation, which they had done in a corresponding group before they had started doing arthroplasty. They found the procedure was actually no more extensive. And they obviously found that the mechanical complications were much lower. However, with the DHS coming into its own in the later part of the 1980s, that became the first method of treating these fractures. And obviously then we went on to nails for the more unstable fractures. So, but in the last 10 or 12 years, there have been a lot of papers comparing the results of primary arthroplasty with either fixation with a nail or a DHS. And this is a study from France, which was quite a large study, which looked at 113 in the nailing group and 137 in the arthroplasty group. This was a multi-center study, but was not randomized. They included unstable fractures, 31A2.2 and 3, and 31A3.3 fractures in this. And these fractures and the patients were matched for age, sex, preoperative Parker scores, the fracture type, and medical comorbidities. And they found in the results that the 3-month mortality was identical in both groups. The mechanical complications were more common in the nailing group, while the functional results were better in the arthroplasty group. And so they concluded the present study validated hip arthroplasty for these patients. However, there was one difference in that the ones who had the arthroplasty were treated by more senior surgeons or more experienced surgeons than the group which was treated by internal fixation or nailing. There's another study which looked at complex unstable intertrochanteric fractures and compared the results of DHS or arthroplasty. And this is showed that in group A, which was compared to group B in terms of blood loss, duration of operation, there were no statistically significant differences. But group A, which was the fixation group, had a higher incidence of device-related complications. And when we looked at Harris hip scores, they were better in group B, that was in the arthroplasty group. So again, in favor of arthroplasty for these unstable trochanteric fractures. And this is a study from Japan, a recent study, which looked at bipolar hemiarthroplasty for unstable intertrochanteric fractures. This was not a comparative study, but they actually looked at CT scans before deciding on which patients to go for arthroplasty. And they found a fairly good result with an excellent to good results of almost 60% of their patients in this group and no additional complications as compared to the fixations that they were doing earlier. Come to the Cochrane Library and the meta-analysis in 2016 from the Cochrane Library showed that there was insufficient evidence from randomized trials to determine whether replacement arthroplasty had any advantage over internal fixation for extracapsular hip fractures, and further larger studies were required to really come to a good conclusion. So I think the issues that come with arthroplasty for in these fractures are the fracture of the trochanter, the entry point, how do you decide length and version? When the calcar is gone, it becomes even more difficult. And of course, they have a high dislocation rate, so as was reported. We also have to be aware of the Kyle variant, where some fractures may have an extension onto the neck. And here's a classical example of a patient we just treated very early, very poor medical risk. And when we looked at the x-rays, it was a situation where we thought we might go for an arthroplasty. So we got a CT scan done. And if you look at this, you can see that the fracture actually extends right into the neck on the posterior part. And that was the head when we took it out that we retrieved in the procedure, and we went on and did a hemiarthroplasty. Similar cases where the trochanter would also be totally avulsed in this situation, you would need to wire the trochanter back as well as do a hemiarthroplasty. And again, in India, we still get patients presenting late. And if you have a very unstable situation with the patient presenting late and very osteoporotic bone, these might be situations. And again, if you look at this lateral x-ray, you can see the fracture extends pretty much close to the neck on this side. And so it would be a situation where we do an arthroplasty. So here, again, you can see what we use the supine position and a modified hard hinge approach, but in these fractures, we work through the fractures. And so we use this position when we look at the tibia and the two epicondyles. That's a good guide to our version. And that is how we control the version of the prosthesis. In this case, we used uncemmented long stem prosthesis because of the we wanted to extend the prosthesis lower down because the fracture extended quite low down. And then we was the postoperative result, wired the greater trochanter back on. So what about revision fixation after failed fixation or complications? I think this is still possible in many situations, but you would again have to consider arthroplasty where this is not possible. If you look at the acetabulum and if that is in a bad shape, you would decide on a total hip replacement. And of course, you have to look at patient factors and then decide whether a hemiarthroplasty like a bipolar would be enough or you would need to do a total hip replacement. So again, like I said, we tend to go the extra mile to preserve the hip where possible. This is a 65-year-old patient, and you'll just go through a series of x-rays. This was treated elsewhere, and you can see with a DHS, which wasn't appropriate in this particular fracture, and not surprisingly, it went on to fail. This implant was removed at 14 months, and she presented to us at 17 months. But again, here, because the joint was okay, and we had a reasonable amount of the trochanter and the proximal femur still there, we decided we would fix it. We used a DHS, we valgusized it, we used bone graft, and we also used a tension band wiring for the abductor mechanism. And you can see this lady with a little bit of medialization went on to heal and had a reasonably good function at 7 months post-op. However, there will be situations where you will have to do an arthroplasty, and this study from China looks at the state of the art of doing revision surgery for failed fixations. And they said you have to look at all these factors: the physiological age, the life expectancy, the bone quality, the hip joint function, and the functional levels in deciding on what you have to do. And of course, if you have a situation like this, where really the trochanteric fracture is beyond reconstruction, it's gone on to becoming almost like a neck fracture. But because the acetabulum or the joint is okay, we could do a bipolar hemiarthroplasty, but you do need to cement the trochanter, wire the trochanter back properly. And here's another situation where a long lock plate was used, went on to fail, also got infected, implant had to be removed. And then finally, when the infection had settled, we went ahead and did a long stem uncemented total hip with a cemented cup and a uncemented stem, because we wanted to bypass all the bone holes that were there due to the previous fixation. So I think you need to look at certain factors when you're doing it for failed fixations. You need to rule out infection. You have to consider removal of the hardware. You have to think about the previous incisions. And of course, you need to look at leg length discrepancy, the trochanteric comminution. Of course, the anatomy will be distorted, especially if they've been fixed before. And you have to also think about stress risers from the previous hardware. So I think primary arthroplasty has a role in some of these fractures, but it's not without its own problems. This I would never do a hemiarthroplasty for a fracture such as this, but hemiarthroplasty has become quite popular for these fractures in India. And this was done by fairly high volume hip arthroplasty surgeons. It wasn't done by someone who was a novice at this. He got a reasonable fixation. The trochanter wire we could argue about that. But this elderly patient who was in his 90s went on to have a periprosthetic fracture. And this was a cemented hip. We had a real job trying to salvage this and do a long stem prosthesis to replace the earlier prosthesis. Also, this study from the Mayo Clinic, which looked at perioperative 30-day mortality after intertrochanteric fractures treated by internal fixation or arthroplasty. And they found that in the 1,873 operated fractures between 1969 and 1997, they had 4.8% 30-day mortality in the arthroplasty group and 4.5% in the fixation group. So not a whole lot of difference, but when they looked at it more closely, they had a significantly higher incidence of major intraoperative complications and the number of patients who died while they were still in hospital in the arthroplasty group. So you have to be aware of the complications when you decide on doing an arthroplasty. So the take-home message is I still think that most trochanteric fractures should be fixed. Look out for the Kyle variants. Rule out pathological fractures. That's something you always need to look out for in some of these elderly patients. I think CT scans are beginning to have a definite role in assessing these fractures more carefully. And for me, I would still reserve arthroplasty for failures of fixation and exceptional situations where fixation is likely to fail. Thank you very much. Stop sharing.
Thank you, John. Unfortunately, we're just about in time, so I'm not able to field any questions for the panel.
Okay.
I've looked to the question and will answer them. It's my duty to thank Mr. Bob Handley, Professor Mohit Bhandari, and Mr. John Upadhyay for sparing the Saturday for us and giving such fascinating overview on this common yet kind of difficult problem that we face day in and day out in our trauma practice. Thank you all. So this brings to an end to this session. Thank you. So the next session is the official address of the President of British Orthopaedic Association. It's my honor to invite Mr. Bob Handley back in. Mr. Handley, as a matter of formal introduction, grew up in London, trained in Sheffield, and then had fellowship, as he said, in Seattle, and has been a orthopedic trauma consultant in a consultant-led practice at Oxford Trauma Unit for the last 27 years. He has held various positions. He has been the past president of AOUK, of the Orthopedic Trauma Society, and is currently, as you know, the president of the British Orthopedic Association. He has been attached to the NICE and also heads the Getting It Right the First Time GIRFT project. Mr. Handley is known to be a teacher, a philosopher, a thinker, and we all have kind of modeled after him and thought to him as our mentors. He has this awfully difficult time or task of leading the British orthopedic community through this challenging pandemic for the last 15 months or so. I'm sure he's got fascinating experience which he would like to share with us. Without further ado, Mr. Bob Handley, President of British Orthopaedic Association.
Thanks very much, Kitish, and good afternoon. It's odd to hear yourself introduced in that way and not be able to stand in front of an audience and speak and gauge a reaction. And it's difficult to know how to make a presidential address via Zoom. So do I present a relaxed figure hiding behind a PowerPoint presentation? I could have taken the camera out into the garden. It's quite sunny here now, strangely in Oxford. It was tipping it down a little while ago. Or do I try and do this like some party political broadcast staring into the camera? Well, I've chosen the latter. I'm going to do it as a party political broadcast looking at you face to face and hoping that there is some reaction. I am a BOA president, but not as you've known it in the past or not as I've known it in the past. I haven't had a single face-to-face meeting during my time with the BOA. So no council meetings, no committee meetings. I've not been anywhere as BOA president yet. This is as far as I've got to my study. I haven't left the UK at all during the last year. So I haven't done the normal go away and represent you all in foreign climes, both from the professional point of view and in a social perspective. In fact, the furthest I've got to is not far from where Kitish is now. I have been down to Swansea with GIRFT. But despite these impediments, as you might imagine, there's quite a lot to report over the last year, and it hasn't been an uninteresting time, to put it mildly. I'm going to touch on three areas which I think are of relevance. One which isn't related to COVID at all, which is a diversity. Another one, COVID itself, and then pathways, which I think are developing and are consequential upon COVID. So to talk about diversity, it's a topic which had come up a lot over the last few years, both within and without the orthopedic sphere. And I think within orthopedics, it was seen to be a particular problem. there aren't many areas of diversity which are easy to measure. The easiest by far is to see how many women there are in a particular group. That statistic comes through. And in terms of the TNO, we didn't seem to be performing particularly well. And that might be for a variety of reasons, whether that's a desire of the individuals to pursue a career in TNO, or whether there are unnecessary impediments in the way of that pursuit. And I think you can see in some respects that in medicine we do quite well, because if you look at the first year of a medical school intake, it's genuinely pretty diverse. There's certainly, in terms of the male-female split, there are more women than men attending medical school now, and ethnically there's a very good mix. But that doesn't mean there aren't hidden areas of lack of diversity or discrimination. And so the educational background that people come from, their social class or such like, may have an impact that we're not able to easily measure or easily monitor. But within orthopedics, there are some particular areas of issue. So if you speak with medical students when you get the opportunity and find out what they believe of the orthopedic surgeon, they tend to have a stereotype of a rugby playing white male as being the most suitable candidate for a career in orthopedics. And that genuinely still persists. If you talk to first year medical students, they will have got that into their mind from somewhere, whether that is parents, TV, peers, I don't know. And it becomes a chicken and egg, because if they don't then wish to pursue the career, they don't have the role models to change that. And I think that the best way to undermine those stereotypes is by having good role models. And there are definitely changes within our community, within the BOA. Last year, there are 4 elected posts to the council each year, and 3 of those were women, and they'll take up their posts in January of next year. But I think you can see how perceptions can be changed. And to draw analogies of other walks of life, I think is quite interesting. So if you take cricket, now I'm an avid test match specialist and have been since I was a kid, and it genuinely would have seemed odd and quite out of place in the past to have a woman commentating. But after a few years, it's now perfectly appropriate, perfectly reasonable, and I'm sure that must have changed the aspirations of women looking to where they're going to try and have their career, because they do see good role models. And I think that's our job, is to try and provide good role models. And if we're not able to provide them ourselves, to put other people into the limelight so that they can do it on our behalves. But even with that, you hear cricket providing another area where you know that there are things which are not good. So I don't know whether any of you will have listened to the great fast bowler Michael Holding's discussion on discrimination. And whilst there were many positives, there were a lot of bad things. And you realise that in society in general, there are things that we have to have our guard continually raised to try and protect ourselves and protect our communities. The BOA has a working group on diversity, and anyone who has ideas that wish to put into that group would be more than welcome. If we move on to looking at some aspects of COVID, the main one which is troubling us at the moment is how the recovery is going to work. And when we heard from the Welsh Minister of Health, that was what was discussed. And that will depend on a balance, as she pointed out, of the demand and the supply. Well, we reckon that the demand will be pretty much unchanged for orthopedics. The main waiting lists that we have are for those people awaiting treatment of degenerative conditions. They're not likely to undegenerate with the passage of time. The patients who are awaiting total joints in particular tend to be of better health than their age-matched contemporaries in the general community, so they're not going to go away. And so we're going to need to meet that unmet demand over the next few years. And how are we going to meet that demand? What facility do we have? What resource do we have? And the major limitation is the workforce, whether that be ours in orthopedic surgery or anaesthetics or theatre workforce or whatever. And if you look at the workforce, you can look at it in 3 areas. Those who are entering it, those who are already within the workforce, are they going to work harder, work weekends, work nights, work 3-day sessions, etc.? And those who are going to exit it, is their retirement going to be brought forward or changed? And at the entrance end, the training is a real issue. Rob Gregory, who's, as you know, chair of the SAC, reckons that there's a good chance that about 25 to 30% of trainees will have to hold back on their CCT date because of lack of completion of training cases. And that's going to pose a huge burden if there are still the expected number of retirements, or God forbid, there are more retirements than would have been the norm. Superimposed on this is the expectation or the hope on the part of the NHS that we'll work harder. They would like people to work extra sessions, to work into the evening or to work at weekends. And it's not clear whether people are going to want to do that. It's also not clear whether people are going to want to are going to see that there's a financial balance to doing that, because there's always in the background the issue relating to pensions and extra work. So one of the ways in which we're trying to approach this is over the next couple of months and before the Congress, we want to do a BOA survey to look at all of those aspects about entry into the career part of our profession, the work rate that people would be willing to accept, and plans on retirement, because we think that that's one of the bigger contributions that we can make on behalf of the profession to seeing whether we're going to be able to meet the unmet demand. Finally, to look at other reorganisations that are going on around us and how that might affect us. There is within England a significant reorganisation towards ICSs, so integrated care services. And there's a move towards pathways of treatment rather than individual episodes of treatment. And I suspect that one of the problems that poses for us, particularly in the trauma aspect of our work, is that a lot of our work is genuinely multidisciplinary. And yet we haven't moved on from the notion that there's only one person's name at the end of the bed. So you may carry the responsibility for the patient, but you don't have much authority to change that around you to implement that responsibility. And I think that in that world of multidisciplinary involvement, we need multidisciplinary authority as well, and multidisciplinary control. And that's going to be difficult to institute. But I think that working as a profession between the various groups, so between those of us that are surgically orientated, the anaesthetists and the allied health professionals, we genuinely need to share that authority and responsibility for the patient's benefit. Finally, I'd like to make an advert on behalf of the BOA. We're still planning to have a face-to-face congress. With luck, there will be 2,500 delegates in Aberdeen. That's the anticipation at the moment, and there's support from the Scottish Government for that in one of their initiatives to try and get larger health-based events back and up and on their feet. So that doesn't include, that 2,500 doesn't include the support staff or representatives from companies or the like. That can be us, the surgeons and members. So I would very much like to see real people in a real place. So I look forward to meeting you in Aberdeen. And finally, thanks again for the invitation to attend and to speak at BIOS. It's a meeting that past BOA presidents have told me that they really enjoyed participating in, and particularly in attending, because it seems to be a family orientated as well as professionally orientated meeting, which I think is an excellent way to go about it. And perhaps I'll be able to see you face to face in another year. So thank you once again.
Thank you, Bob. May I please request the new president of BIOS, Professor Amit Tola, to say a few lines in response.
Hi, Bob. I'm very grateful to you on behalf of the Society for having given up your time on a Saturday afternoon to talk to us. It was very apt and appropriate. Inclusiveness is very close to our heart, and our society should be also moving in that direction. All the problems that we face on a day-to-day basis, I'm sure these things will hopefully even itself out with time. And yes, we missed you to come here because of this being a virtual meeting and the effect of the pandemic. But hopefully we will all meet up in Aberdeen and on a face-to-face basis. So thank you once again.